Does it appear to you that children seem to suffer from many respiratory emergencies? Well, that's because they do, and you will see why in our next segment. Respiratory problems in children seem to go hand in hand. But why? To find out, we recently sat down with Dr. Jessica Prince, Medical Director of the Palm Beach Children's Medical Center at St. Mary's Hospital, to get some answers.
So children, on the whole, you basically need to think of it as that they're smaller. So the whole mechanics of breathing is different. They have smaller lung volumes, which means that when they breathe in air, they're not breathing in the same amount of air as an adult is. And on the whole, their functional residual capacity, the air that they have left in their lungs as reserve for when they do get in trouble and have respiratory distress, is much less than an adult. So when they get into trouble, they can decompensate very, very quickly. As a parent or as a medical caretaker, when you look at children, you can tell if they're comfortable or if they're in distress. So we go by something called Pediatric Assessment Triangle, PAT. And it's very simple, it only takes a few seconds to do. The first part of it is appearance. So what does the child look like? Are they distressed? Are they anxious? Are they somnolent? Are they lethargic? All of those signs are signs of hypoxia, that they're not having good gas exchange or they're not able to provide oxygen to their tissues.
Is she breathing? Is she having trouble breathing? Get up, 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 get up. Are you okay? Are you okay? Oh my gosh, she needs her inhaler. Breathe, relax, relax. Give me my purse, give me my purse. Give me my purse. I don't have it. I forgot to.
So the second part of the pediatric assessment triangle is breathing. What does the child look like overall? Can you see that their nose is flaring out, that they're retracting, that they're moving their belly? Are they in respiratory distress?
Okay, yes. Yes. Okay, yes. My name's Elise. I need help. My daughter, I think she's having an asthma attack. She's not breathing really good.
So the third part of the pediatric assessment trial is circulation. Things to look for is a patient cyanotic. So in infants, there's a difference between what we call peripheral cyanosis and central cyanosis. A lot of times with especially newborns, you'll get a little bit of a bluish color in the hands or the feet, or sometimes when they're feeding, around the mouth they'll turn blue. That's okay, that's something we call peripheral cyanosis. But if you start to see that the lips turn blue or that the whole body becomes an ashen color, that's troublesome, that's worrisome, that's definitely time to call 911 and bring your child to the ER. Children have many different signals to give you. The first thing would be just looking at the baby. If the baby or the infant or child looks uncomfortable and they can't speak to you, you need to be concerned right away that it's a respiratory issue and that it could be partial obstruction or obstruction. Other signs that may give this away is that the child refuses to swallow, that the drool is coming out of their mouth or they're spitting it out if they're an older child. If they're having difficulty talking, if they have a funny muffled voice, that's another sign that there's some upper airway obstruction. If a baby is grunting, definitely a sign of respiratory distress. And there's also sounds that you can hear. There's sounds called stridor, wheezing, that sometimes we can only hear with an otoscope, but sometimes it's such a loud sound that you can hear standing at the doorway from across the room.
What's going on?
Oh my God, she's having trouble breathing. She has asthma. And
other things to look for is position of the child. So little babies, especially if they're kind of arching their neck backwards and sticking their chin out forward, that's a compensatory mechanism to try and keep their airway open. And there's another position that we see, especially with older children, it's called the tripod position. And what they do is they put their hands forward and they put their body weight forward onto their hands. And what that does is help them to open up their airway so that they can increase airflow. Monitors are a great tool, but the number one rule of thumb is look at your patient. So the the patient, you're looking at them, you know that they're in respiratory distress. You see the retractions, you see the abdominal breathing, you see that the skin's getting pulled out in suprasternally, you see the nasal flaring. And kids have a great ability to compensate initially.
Okay, sweetie, we're gonna take care of you. What's her name?
Her Amber Shea.
Amber Shea?
Amber
Okay.
Shea.
And she has asthma?
She has asthma. She has asthma. She's having trouble breathing. I can tell.
So if you have a child who's really what we call work of breathing, who's got a very increased work of breathing, they may still have a good respiratory rate or maybe a little tachypnic. They may have a good oxygen saturation even though you're not giving them supplemental oxygen, but they're compensating. So if you're using a pulse ox monitor, the pulse ox is a late finding. So as soon as you start seeing the oxygen saturation going down, you know you're already behind the 8 ball. The decompensating part has already started and you only have a very short amount of time to secure an airway on the child.
And vitamins, that's all she takes.
Is she allergic to any medication?
She's allergic to like 4 different things, like erythromycin, ampicillin, Rocephin, Duracef.
Some of these we've already talked about a little bit. When you're talking about infants and sometimes a little bit of the older child, they will make a noise called grunting. Grunting is basically the equivalent of what we do with a ventilator by using what's called PEEP. It's end expiratory pressure. So when you grunt, you're increasing the pressure to try and keep your lower airways open to keep the oxygen flow going down into the lower airways for ventilation. Another one, very common, that we see all the time is wheezing. Wheezing is actually, in a sense, divided into 2 parts. There's wheezing and then there's stridor. When you hear stridor, stridor is an inspiratory wheeze. So it's going to be upper airway obstruction and you're going to hear it when the patient takes a breath in. The other definition of wheezing, which we just call wheezing, is usually more towards end inspiration and majority of the time expiratory phase, so when you're breathing out, and that's a sign of lower respiratory illness.
Okay, we're gonna treat her. We're gonna take over to West Boca Hospital. It's a pediatric facility, okay?
Okay, can we go with you there so we can yeah,
You can run.
Maintaining a child's airway, the basic principles of it are the same as an adult, but children's airways are very different than adults. Again, just like an adult, you want to make sure that the child's head is midline, but then we start running into the differences. So a child's head, especially a younger child, has a very large occiput, so the back of the head is larger than comparatively to an adult. So when you lie the child flat, the head ends up getting pushed forward and includes the airway. So what you want to do, especially with the young infants, if you're trying, especially when you're trying to intubate them, or just as a comfort measure, sometimes just doing a towel roll and putting it right underneath the shoulders, right at the top of the shoulders, to help lift up the chin and open the airway is all you need to improve the airflow into the airway. Sometimes once you do that, you realize you don't have to intubate the child. Another thing is a child's tongue is much larger comparative to size to the mouth compared to an adult. And a child who's lethargic, somnolent, and whose tongue is occluding the airway, you can do something called an oropharyngeal airway, but you do have to be careful with those because you cannot put one of these in if the child has a gag reflex. If you try to put one in, you will cause or induce vomiting, which is never a good thing, especially when somebody's in respiratory distress, because you could end up causing aspiration. But if they have no gag reflex, even just putting in an oropharyngeal airway may save you an intubation. Croup and epiglottitis are both upper airway obstructions that are caused because of infection. Epiglottitis is something that we heard a lot about in the past. It's in our textbooks over and over again. It's a very emergent upper airway obstruction that when we see it, we need to be extremely careful with it. We haven't seen it too much lately in the past 20 years because of the advent of vaccines, but now that more and more parents are deciding not to vaccinate our children, we need to be very aware that epiglottitis is a very real in live happening again. Basically, you have an epiglottis, it becomes infected, and it inflames, enlarges, and you block the airway. It is a true pediatric emergency. Croup can also be a pediatric emergency. Often there are seasons for croup. Often you will have parents bring their child in because of a barky sounding cough. That's the number one complaint with croup. And croup is also one of those illnesses that you start to hear stridor. Same with epiglottitis because it's an upper airway obstruction. Basic croup we can treat in the emergency room with steroids. There's a breathing treatment that we could give if needed. Epiglottitis, though, is a completely different ballgame. A lot of times it needs an emergent airway with antibiotics for treatment. If you're concerned, call 911. We don't want you to wait too long and have it be a true pediatric emergency by the time you call EMS or bring your child to the ER. There are signs that you can look for: nasal flaring, retractions, anxiety with that, the child grabbing at the throat, a lot of coughing, turning red and vomiting with coughing. I mean, the list goes on. And the rule of thumb is if you're uncomfortable with what's going on, if you can see your pediatrician right away, great. If it takes too long to see your pediatrician and you don't want to wait that long, just go ahead and call 911 or bring your child to the emergency department. We'd much rather see a child with a cold that is going to do fine at home than to see you come in with a patient that we have to do an emergent airway on.
Hold this, put your mouth around that, take nice deep breaths. Good, nice deep breaths. You're doing great.
Well, that's it for now. Hope you've picked up a few things. For more information, contact the Training and Safety Division. I'm Charlie Coyle. Thanks for watching, and remember, stay safe.